Thank you for having me, and it was a pleasure working with the writing group on this. Statement, I have no disclosures, and the objectives of the second part of the talk, which is my part, is really to go over what the update addressed that is different than the 2017 statement on cardiac imaging in acute Kawasaki disease. And some of it was covered by Dr. Harashi, so I will not go over it again. I will address a few points that are specific to echocardiographers. I will touch upon the long-term follow-up and surveillance of our patient, the management of acute coronary syndrome, and the transition. So in terms of cardiac imaging, echo remains the primary imaging modality to look for the cardiac complications that we see in Kawasaki disease and to guide the management of Kawasaki disease. But again, we emphasize in the statement that it should not delay treatment. And as Ashraf mentioned, might need sedation in young children because we are really looking at vessels that are millimeter in dimensions, and each millimeter, as you will see, counts. Other imaging modalities are rarely used in the acute period unless the echo is suboptimal or doesn't answer the question. The statement has this table that summarizes how to prep the patient for the echo, what are we looking for on echo, and how to qualitatively and quantitatively assess the coronary arteries, which views to use to evaluate the coronary arteries. And I highlighted a point that the statement made, which is it is reasonable in patients who have had, who are high risk, considered high risk in the acute phase, which is the young patients less than 6 months or those with aneurysms at baseline. It's quite reasonable for them to have repeat echoes every 2 to 3 days until their coronary artery dimension stabilize, because these patients might benefit from intensification of therapy beyond the IVIG, be it adjunct or rescue. And this is an example. This is a patient who on day 0 had a small aneurysm, as you can see here on this parasternal short axis in the right coronary artery, and had on frequent surveillance, we found that on day 14, and he was at this time still in the hospital, that aneurysm actually grew. This would be considered a high-risk patient based on the statement because they had aneurysms at baseline. And then another thing, the statement emphasized is the importance of accurate measurements, inner edge to inner edge, the importance of the reason, we go through the technicalities of how to image the coronaries is because these accurate measurements require high resolution images and a lot of tweaking when you're imaging the patient. It's very important not to measure at the bifurcation points to avoid overestimating size. Sometimes the left main has an early branching. And so you have to avoid measuring at that point. And then it's important to measure the proximal RCA and the left main 3 to 5 millimeters from their origin. And as you know, the statement continues to quantitatively assess aneurysms based on Z-scores. It's important to make sure, again, that the reason we advocate for accurate measurements is because small error in measurements can translate into a larger difference in Z-score and have the patient move categories, be classified into medium as opposed to small or vice versa. And it's very important since Z-scores are normalization to body surface area to get accurate height and weight for the body surface area. And then finally, the statement also advocated for centers using the same Z-score calculators for monitoring the patients, because studies have found that when you look at a large population of patients and you use different Z-scores, at least the ones we use mostly in North America, that the different Z-score calculators classify aneurysms into different categories. And that would definitely affect management. Long-term follow-up. So long-term follow-up is divided into the frequency of cardiology visits and echo assessment. When do we use advanced imaging and how often? Who receives antiplatelet and who receives anticoagulation? How often and which patient benefits from testing for inducible ischemia and the promotion of counseling on cardiovascular health. So beyond the acute and subacute phase, the risk stratification of the patient or classification really relies on the maximal Z-score that patient achieved, and also that Z-score on follow-up. And so you actually see that the coronary arteries are further divided into, so for example, the small aneurysms is a 3.1 if it's a small and it persists, but it is a 3.2 if we started with a small aneurysm that regressed. And same thing for the medium and large aneurysms. And that's important to note. You can always refer to that table when you see those numbers in order to know where your patient falls. Because we tailor the follow-up frequency and management on long-term follow-up based on these sub classifications. So, for example, you see that the larger the aneurysm and the more persistent that aneurysm is, the more that you will follow the more closely you will follow the patient. One thing that the statement suggested or advised was that patients that are started with a small aneurysm Z-score less than 5 and that regress, they may be discharged pending a normal stress test and a normal coronary CT angiogram. And that is different than from the prior statement. And I will go over why the literature that supports that. So the International Kawasaki Disease Registry looked at 1,600 patients with Kawasaki disease and aneurysms from North America, Canada, and Taiwan. And they found that over a 10-year period, those with small aneurysms, the majority of these patients had regressions of their aneurysms, and there were no major adverse events in those with Z-scores less than or equal to 5, so those with small aneurysms. And similarly, in Japan, a study looking at a multi-center study, I think it was from 2018, that looked at 1,000 patients, also found similar findings. So that's why the statement advocated that if these patients have normal regression, meaning that the artery regressed to normal size, not because it's stenosed, but because it's actually it actually regressed, then and the stress test is normal and the coronary CTA is normal, it's not showing stenosis, then these patients may be discharged from pediatric cardiology to go back to their pediatrician. In terms of advanced imaging, and by advanced imaging in the long-term follow-up, we're talking about cross-sectional imaging in this particular category. Stress testing I will address separately, but essentially it's to look for coronary artery stenosis and monitor coronary artery wall changes like wall thickening and calcification. And you can refer to the table, the long-term follow-up table, to go over and the paper to go over the imaging modalities that are available. But it's important to also note that the choice really depends on what is the question, what is the age of the patient, what is the expertise at the center, and always thinking about minimizing exposure to ionizing radiation, because as you will see, and as you know, these are children. We diagnose Kawasaki disease in children. They will be followed lifelong, and so they will be getting those tests often. And so it's important to ensure that we're not increasing their cumulative dose of ionizing radiation over their lifetime. Now, one of the things the reason we mentioned these four kind of these 4 points in making a choice for what imaging modality to use is because, for example, if you have a 4-year-old where you are interested in looking at whether this patient, beyond echo, this patient has coronary artery stenosis, or a coronary artery thrombus, you might decide to go down the CT route. But you want to make sure that your center has the expertise in looking at coronaries in 4-year-olds, accounting for fast heart rates and all the things that come with it. But if you are actually wanting to see if, there are perfusion defects or there are be it at rest or with stress, you might go down an MRI route. So it's very important to always talk to your advanced imaging specialist at your center in order to make sure you order the right test. And one of the things that the statement also supported is you may consider a coronary CTA in those with persistent aneurysms at 1 year to look for to look at the distal coronary arteries, and specifically in those with moderate to giant aneurysms to look for coronary artery stenosis. And in terms of what is different about the advanced imaging data or the literature that we have, we do know that, for example, with CT, you can visualize all the segments of the coronary arteries, even the tree. It correlates well with cath. It's detecting stenosis 50% and coronary artery thrombosis. You can get a calcium score on a non-contrast CT. You can also, and also with the newer technology, radiation exposure is much less. But it's also important to note that there's no normative data in children yet. I know groups are working on it. So we do use echo Z scores. And it's important to note that the measurements that we often get on CT tend to be smaller than echo. And for antiplatelets and anticoagulation, low dose aspirin remains the cornerstone. For antiplatelet therapy, you might consider dual antiplatelet therapy with clopidogrel in those with persistent medium aneurysms. So that's 4.1. And those with giant aneurysms that persist or giant aneurysms that regress to medium. What is different about the statement in 2024 is in terms of anticoagulation, is the introduction of the direct oral anticoagulants. It's important to note that, the statement continues to support anticoagulation for giant aneurysms, even those that regress to small because of their high risk of adverse events and thrombosis. And I wanted to go over the literature that kind of looked at the direct oral anticoagulants specifically in children, specifically in Kawasaki disease. The first multi-center randomized trial was edoxaban, that looked at prevention of thromboembolism in pediatric patients, be it venous or arterial. The majority of those those at risk for arterial thrombosis were obviously Kawasaki disease, 24 in the edoxaban group, and they were compared to standard of care, which included either warfarin or Coumadin, and they were found to be safe and well tolerated. And because the number of events is pretty small, meaning the number of children who actually had thrombosis in either group was pretty small. It wasn't able to talk about the efficacy of edoxaban, but it found that it was as good as a standard of care. Similarly with apixaban, it's given twice daily, and it was evaluated in children as well, and was found to be safe and well tolerated. And the ease of use of these medications, they're both given orally. They don't require frequent monitoring, make them attractive to use in children with Kawasaki disease instead of our standard of care. Yet we really still need studies to look at their on long term and in the real world use. How do they do? In terms of inducible ischemia and stress imaging, again, it is recommended even for those with small aneurysms, less frequently than those with, giant aneurysms. But it's also important to note that in those with giant aneurysms, we recommend it even if they're completely asymptomatic, because they do have an increased incidence. Again, looking at the same IKDR study, there is an increased risk of major adverse events over a 10-year period in this patient population, regardless of symptoms. And one of the tests that can be used is stress echo. It is especially in children who are older than 7. It is exercise is actually more physiologic, but may be limited by the rapid heart drop in children. It does look at regional wall motion abnormality and does not look at perfusion. So when ischemia starts, usually it starts with a perfusion defect followed by regional wall motion abnormality. But in this single center study, looking at patients with Kawasaki disease and aneurysms who got stress echo, it was able to identify those in the with moderate aneurysms and giant aneurysms who had abnormal stress echoes, so who were at risk for ischemic events. Pharmacologic testing with dobutamine is feasible in those who cannot exercise, but it is associated with a high risk of rhythm problems. And stress MR obviously can look at both regional wall motion abnormality, contractility with dobutamine, or perfusion defect with adenosines and adenosine agonists. But it does require it. It is high resource. It requires a lot of resources, so often you see it in high resource settings, and it might require general anesthesia. So, but it has been used in a lot of centers to look at those patients who are at risk on surveillance, who are at risk for uh, um, inducible ischemia, but also in diagnosing those patients who might need intervention. Finally, in terms of promoting counseling for cardiovascular health, obviously for all patients and at every visit, and those patients who are on either dual antiplatelet therapy or anticoagulation, you would consider limiting contact, and the patients, and you would recommend like self-restriction. In terms of acute coronary syndrome, I think what was great about the statement is it took into consideration expert opinion in the management of acute coronary syndrome in children with Kawasaki disease, as well as the adult statements and guidelines, and created a pathway for those for children and adults with Kawasaki disease. And the reason as pediatric cardiologists is important for us to know it, and as pediatricians as well, is because the risk of MI in Kawasaki disease, mainly in those with giant aneurysms, is highest within the first 2 to 3 months after the diagnosis, and highest in the first 2 years based on the data from Japan, and similarly in the data from North America, looking at these Kaplan-Meier curves, but that risk persists. So it's very important to know that we might encounter these children as kids, and we might see them as adults. And it's also important to note that their presentation might be different. Those with stable angina can have an insidious and atypical presentation because the stenosis can be progressive, because they can develop collaterals, and often they might show up with reversible ischemia on stress imaging. And you also see that those with z-scores more than 10 have an increased risk over their lifetime to develop coronary artery stenosis. So if MI is suspected, it's important to note that the symptoms differ between young children and older children. So infants and young children might present with inconsolable crying, restlessness, sweating, pallor. Older children might have the more common chest or arm pain, but they could also have abdominal pain. They could be completely asymptomatic. They could present with breathlessness, vomiting, and discoloration of the skin. And if that's the case, the child will go to the closest emergency room, will get a 12-lead EKG, troponin, and IV access, and would get a coagulation profile testing. And in the event that they require thrombolysis, and also, as Ashraf mentioned, these families who have children at risk for MI get CPR training. The child would get aspirin, morphine for chest pain, and oxygen for desaturation, and would, after consulting with pediatric cardiology, might consider transfer to an experienced cardiac surgical center in the event that the closest emergency room is not in an experienced cardiac surgical center. Okay, so if this was an ST elevated MI, then and the time to the cath lab is less than 90 minutes, then you would consider urgent percutaneous coronary intervention. If coronary flow is restored, if that's a yes, then you start post therapy consideration, which includes antiplatelet therapy, which also includes beta blockers and statins and ACE, but though within 24 hours after presentation. If the coronary flow is not restored, or if the cath lab is more than 90 minutes, or PCI is not possible because it's a small patient, then you would consider thrombolysis or CABG. And the thrombolytic therapy could be TPA. And you would, the thrombolytic therapy would be TPA, and then you would monitor your fibrinogen and antithrombin 3 level, and you might give heparin in an IV but in an IV line that's different than your actual TPA. If this was a non-ST elevated acute coronary syndrome, meaning there's elevated troponin but a non-specific ST or T wave changes on EKG, then you would start heparin, you would do serial troponins, EKG, and you do urgent imaging by echo and CTA. To look for thrombosis or stenosis. If there is thrombosis, you can consider thrombolysis or PCI based on what was mentioned previously, cath lab time and size of the patient. If it's stenosis, you can consider PCI or CABG if necessary. And the statement also advocated for the development of a heart team in those specialized centers that see these patients that is made of pediatric and adult cardiologist, pediatric and adult interventionist, and pediatric and adult cardiac surgeon in order to work together to take care of the patients. Finally, in terms of transition, I refer you to the paper that was written by Dr. Dada on the importance of transitioning patients with Kawasaki disease and persistent aneurysms from the pediatric world into the adult world, how to prepare them, how to initiate the transfer safely, and how they would integrate into adult care. And this is what the statement advocated for. And so this concludes my part of the talk. And as Ashraf mentioned, we still have controversies as to what is the best treatment for intensification for those who are considered high risk. What is the best anticoagulation strategy? As these patients get older and get pregnant, how do we manage them? And several unanswered questions. I do think that the statement added to the 2017 and a lot of the areas that we just mentioned. Thank you.